Hello everyone, welcome to today's webinar. We're lucky to be joined today from Perth by Doug Carey, and Doug is going to talk about sleep and spinal pain.
Thanks, Peter, very much for inviting me along to join colleagues in discussing some information about, I guess, the clinical implications of my research around the areas of sleep. I do want to go through, I guess you call it the snooze summary. So if you happen to fall asleep somewhere during this presentation, at least just remember this is what we were going to talk about. And then when we get to the question time at the end, you can just hit me up for things that you may be missed out on. So first of all, we're going to look at the influence of insomnia, which basically means poor quality sleep, quantity or quality, and particularly on pain. I thought that would be relevant for you because, like me, you're clinicians, you treat, I would say 90% of people that walk in your clinic door are going to be complaining of pain. So what's the relationship between insomnia and pain? And we know that pain is multifactorial. So we kind of want to know, where does sleep fit into that paradigm, and guess leading on to that, what are we going to do about it? So we know that sleep and pain are bidirectional, but what's the antecedent factor in regards to this relationship? To do that, we're going to have to delve into a little bit of biomechanics. So we can look at the biomechanics of sleep and pain, and ask the obvious question also, is this within our scope of practice? I'd be interested to hear from you as osteopaths, what you sort of, with your professional debate at the moment about what you should do and what you can do and what you can't do. So that might be something that we can look at as well, but I'll give it from the perspective of physios, because that's what I am. And I do have a few interactions with other professionals, so maybe we can have that as a bit of discussion. And then I wanted to give you some of the subjective and the objective examination tips that I use clinically to flag to me that I need to go into a deeper discussion with regards to this person about their sleep. And then basically, what can we offer in regards to the management of the presentations? So that's the kind of summary of what we're going through over the next hour. And let's kick on. As Peter had mentioned, if you want to converse with me, so I know there's somebody out there, it's always nice, just hit it up in the chat box. And if that's a specific question, like, can you look at this or that, depending on time, I'll try and, at least broach that subject with you. Okay, so how did I become interested in sleep? Well, it wasn't because I'm a bad sleeper. And that's often when you talk about PhDs, people say, I did this because I have a problem with this, or my mother-in-law has a problem with this, and that got me interested. But I'm actually a really good sleeper. So the idea, or the light bulb moment for me, actually came from patients. So a good example is Jane, who's a FIFO worker. And she'd experienced for many years this episodic low back pain. It was not traumatic. There's no reason for onset. It was generally worse in the morning. And essentially, she was pretty frustrated because no one had been able to assist her, and she was confused as to why her pain got worse at night when nighttime was supposed to be rest and recovery. And she also reported that she was pretty restless in her sleep, so flopping from side to side. And in the morning, her bed kind of looked a bit like a war zone. So clinically, we just eliminated the red flags, got rid of the saucy reasons for a nighttime aerobics. And it seemed to come down basically to her sleep system, which is what we term the pillow, the mattress, and the base, or her sleep posture. And being a FIFO worker, it was pretty handy because it meant that she slept on different beds, so different camp beds and different beds at home. Meant that if the problem consisted or was persistent through those different sleep system environments, it sort of came down to a sleep posture. So that was kind of, for me, the light bulb moment to think, well, okay, what do I know about sleep posture in regards to causing and precipitating pain? So before we dive in much deeper into that aspect, we're just going to introduce 3 case studies that we're going to elaborate on through the course of this presentation. And it's just to try and bring some depth and some reality to the types of patients that I would see, and I'm assuming you guys would also see them, and go a little bit underneath the general MUSC presentation that we'd see and look at it from a sleep perspective as well. So the first one is Josh. He's just a young basketball player who had an acute inversion ankle sprain. Matt's a police detective, and he presents with chronic plantar fasciitis. And Emma is a mum of 3 young children who clinically wants to improve her physical capacity, having gone through those childbearing years. And she wouldn't mind losing a bit of kilos into that bargain as well. So on the face of it, they're sort of 3 different but pretty standard mask presentations that I'm sure you guys all see daily in the clinical situation. But I'm going to throw a little curveball in there and say that these cases can be very much related, and as primary contact practitioners, we need to understand a different aspect that perhaps we're not considering so far. And that's going to be discussed a bit later on. So there are 3 people that we're going to be talking about. Okay, so what did we know? So this is now going back to the standard approach. You don't know something, you go to Google, you do a lit search, and it's the same thing for doing your master's and your PhD. You do a lit search and you look at what information is available. Well, in 2011, there was a plethora of anecdotal information, lots of websites saying you should sleep like this, you should do this, you shouldn't do that. But absolutely just about 0 research-based evidence on which you give a patient an evidence-informed decision about when they ask you, what should I do with regards to my sleep posture? So that was pretty interesting. That was 2011. And that got me started on my master's, and then studying part-time was a little bit slow out of the gate. But by the time I got doing my PhD, it came around to my supervisor saying, well, we've been a little bit slow in this area. You might want to do a follow-up lit review, which then became a scoping review, just to see if it has leapfrogged us and is providing this type of information, and we're a little bit late to the party. So in 2019, we published a scoping review, which looked at this question of what are the relationships between sleep posture, waking spinal symptoms, and sleep quality. And we found about 4,200 articles touching on these subjects. But when we did this standard process of narrowing it down to the specifics, we found that there were only 4 now still talking about this. So just think about, in your clinical situation, how many people come to you over a course of a month and say, look, I went to bed feeling fine and I wake up in the morning with neck pain or back pain. Does anyone have that happen to them clinically? Just whack that into the chat box. I'd be really interested to see if I'm speaking to people that have the same experience as I do clinically, or I'm talking about something that perhaps is not that relevant to you guys. So just throw some messages in the chat box. Oh, good. All right. Thanks, Thomas. I'm glad we are clinically on the same page. Okay. Thanks, Penny. So and that sort of to me was quite interesting. Cheers, Rob. Oh, thanks, guys. That's good. All right. So what we're doing is that we're sort of saying that clinically we see patients. Research-wise, we don't have an evidence base in which we can just sort of provide them with appropriate information. Now, you can get that article. It's open access, so that's available. So in 2022, so just recently, I had another look. I didn't do a full scope review because that's very painful, but it became pretty obvious that we don't still have a lot of information. And of those 4 articles at that time, 2019, one was one of ours, and we've done 3 since then. So the barrier has been pushed outwards for sure, and that's sort of where we're heading. Okay, so you can't really talk about this whole area of sleep and not sleeping without understanding something to do with insomnia. Now, insomnia is just a term that relates to poor quality and or poor quantity of sleep. So where they're looking at the prevalence in the population, it's around about 30 to 45% of the adult population. Now, that can mean getting to sleep, difficulty staying asleep, or experiencing fragmented sleep. So 1/3 or more of the adult population is experiencing that. And that's pretty relevant because that means 1 in 3 patients that's sitting in your waiting room on Wednesday morning is going to be experiencing some degree of sleep difficulty. And therefore, this is going to lead on to why it's relevant for us to look at it. The picture, however, is actually getting worse than that. So over the last 40 years on Sleep Review, they're finding that this is American data, that people are sleeping 1.5 to 2 hours less per night than they were 40 years ago. So standard sleep is, for adults is around 7 to 8 hours. That's sort of the magical numbers. Once you start below 6, you start to get some significant health issues accruing from that deficiency, and they call that short sleeping. Now, a sleeping deficiency can be described as being acute. An example of that would be like an upcoming examination, or I've got a presentation like this and not sleeping the night before, or maybe the death of the pet. So usually it's transient, it's short-lived, and you move back into a normal sleep cycle once that initial stress has gone past. Chronic insomnia is by definition something which has occurred for usually about 3 months. So you have broken sleep, difficulty getting to sleep or staying asleep for a period of 3 months or more. And that means that people are experiencing on an ongoing process or period of time disrupted sleep, and it's not helping them. Now, that leads to a series of health things. Now, we're talking about pain now, but I just really want to broach this because it's relevant in the sense that there are multiple systems that get affected, and some of them you might be familiar with, and some are going to probably, literally confuse you. So one is reduced fertility. So both male and female, and in case of male, it's more dysfunctional sperm. It's more or less sperm content and less sperm activity. In the females, it's a less egg production, and also a thing called feductibility, which means less efficiency of egg fertilization. So both the male and the females are affected by short sleeping. Mental health is a big thing. Like, it doesn't take much of a brain leap to realize if you're not getting sleep, you're going to have difficulty concentrating. Days are going to look darker. You're not going to be as effective at work. You might be concerned about how you're going to perform the next day. So anxiety and depression are intimately entwined with short sleeping. Learning and memory is very interesting. Nighttime is a period of time where our brain does a lot of housekeeping. The brain literally shrinks, and the gaps between the brain open up. So there's a lot of house cleaning goes on through the flow of fluid in and around the brain. And that's been sort of noted in the last 5 or 6 years. That's been a bit of an interesting thing. But basically, the information that we take in during a day goes into a short-term storage system. And at night time, that short-term storage system is downloaded to our motor cortex and our memory cortex. And if that download doesn't occur, and that takes a certain period of time, then our short-term system stays chocked. And when we wake up the next morning, it hasn't completely downloaded. So then we can't, or we're limited in what we can take in. So both learning and memory are influenced by a lack of sleep. And that's when it gets worrying, when you start hearing state governments talk about, we want to start school an hour earlier and things like that, because teenagers, particularly, like adults, we take 7 or 8 hours sleep as our norm, but kids are like 10 to 12 hours. So if you start getting them to school earlier, it means they haven't had sufficient sleep. And if they haven't had sufficient sleep, they haven't downloaded and integrated what they learned the day before, and it becomes a downward treadmill. So even though you think they're spending another hour at school, the downside is that their brain is not taking it on. So it's kind of a waste of time. Weight gain is interesting. Well, we'll look at that with regards to Emma, but essentially we have hormones in our body which regulate how hungry we feel. And the ratio is that when we short sleep, we have more of a hormone called ghrelin, which makes us basically feel less sated or more hungry. And we have the urge to eat not only more food, more calories, more salty, more fatty food, but our reward system, our cannabinoids actually trigger in as well, and they reward us to eat more. So if you're helping people lose weight and they're not getting that adequate sleep, you're really working against an uphill battle in regards to the hormonal systems. And immune function. So immune function is depressed if we are short sleeping, to the point that the recommendation is if you don't get a solid 7 or 8 hours sleep, the 3 or 4 nights before you have your flu injection or your COVID injection or any immune type injection, it means you're probably not worth having it, because essentially your immune system is not going to react to it, and therefore there's no point doing it. So sleeping is going to affect the function of your immune system as well. And there's a massive literature about their metabolic and cardiovascular disease. So hypertension, strokes, heart attacks, they all go up if you are short sleeping. So if we're looking at a person in a holistic way, then there are some significant health systems. Or in fact, there's probably not any health system in the body which is not adversely affected if you're not getting sufficient sleep. So just wanted to touch upon those, because it's not just pain which we're going to deal with. There are other significant things. Oh yeah, and just as a minor point, your death rate goes up if you're not sleeping well either. So just a minor consideration for your patients. Okay, insomnia, acute and or chronic. We've talked about that. The we divide insomnia into primary and secondary. So primary insomnia relates to insomnia or poor sleep, which is due to no physical, no mental, and no environmental reason. So it's to do with the sleep cycle itself. It only affects 1 to 10% of people in an adult population, but it does rise to about 25% in the elderly. So more older people have primary insomnia. The other form of insomnia, which is the more common format, is secondary insomnia. Now, that means there is an actual underlying pathology which is causing the person to have poor sleep. And a New Zealand primary practice group did a study 2012, so 10 years ago, because they actually wanted to find out in a primary contact situation, what were the causes, what were the most prevalent causes of secondary insomnia, given that that was the most common cause of the two. Number one is anxiety. So the number one reason that people don't get to sleep at night is anxiety, quickly followed by depression, but anxiety had the lead. Limb movement disorders like restless leg and periodic limb movement disorders were the two ones after that. And then sleep apnea, which is when people have apneic periods, regularly through the hour, usually 20 to 30. That prevents them from getting into deep sleep, and then that causes a lot of issues, particularly with the cardiovascular system. Pain was another one. So think about your patients that present, say, with a hip replacement, or they've just fractured a rib. They're classic examples of people who would have secondary insomnia as a result of a painful condition. Okay, so we're focusing particularly on pain, which was that last one. And it's looking and understanding that pain is bidirectional. So that means, and quite logically, if you have a poor night's sleep, your pain levels are probably going to be up the next day. And just like we saw, if you have pain, that's going to affect the quality of your sleep. So pain is bidirectional. And that means that we want to sort of work out, well, okay, which one comes first? And when they use longitudinal studies to do this, and there have been several longitudinal studies examining this particular thing. And although it's not concrete, definitely, it seems that sleep is the antecedent factor. And what they've found is that they've taken populations of healthy individuals, so they be pre-adolescents, adolescents, young adults or adults, all healthy ones with no pain, and they then subject them to short sleep. And what they found out is that those patients, it becomes predictive. So if you are healthy and you're subjected to short sleep, you will develop musculoskeletal painful conditions as a result of that short sleeping process. So as primary contact practitioners, that to me was like, wow, this is a real eye-opener, because treating pain is my bread and butter. Probably 90% of patients would have pain as their major complaint. 10% of the enlightened ones would come in and say, look, I'm a bit concerned about this, and before it becomes a problem, I want some preventative strategies. And I just about jump up and down and go, hallelujah, wish we had more of you guys around. But most of the people that we treat are going to be presenting with pain. So given that it's predictive of pain in pretty much the whole spectrum of the patients that we are treating, that would seem to be the logical question to ask is, do you automatically screen all your patients with pain for the quality and the amount of sleep that they get? So Pete's going to throw up a little poll, and he's just going to ask that question. I'd like to know from you, do you routinely ask sleep quality and quantity questions of your patients that present with pain? So I'm looking forward to some very interesting questions, because you guys are going to have some good follow-up stuff in regards to what this is about. Okay, so it's predictive, and we need to be aware that it's going to cause some of the musculoskeletal pain presentations that we have. And more importantly, it's going to propagate some as well. So there's that sleep domain that we've got to be considering. Thanks for doing that, Peter. All right, so firstly, there's two things. We talked about sleep as being a predictive element of causing pain. And that's probably I would have thought, the more unusual way of considering the relationship between pain and sleep. The more common one that is what led me into my research was I went to bed feeling good. I woke up in the morning with acute neck pain or stiff low back. Everyone would be very familiar, I guess, with the cervical acute torticollis, where you so-called lock neck, or however you want to phrase it. And in the low back, I call it the short arm syndrome, which it's not really a syndrome. It just means that they get out of bed and they say, I don't know what happened the night, but I can't touch my toes. I can't pull on my socks. It seems like my arms got shortened. But essentially what they're saying is their low backs become stiff and painful and they can't comfortably flex forward. So we came back to Jane, who was our FIFO person. She had this exact same thing. And we were questioning, like, is it her sleep posture, given that she was changing her bed? Now, the most, what would you call it? The most demonized posture in the literature, well, in the general anecdotal stuff, is sleeping prone. And that kind of makes logical sense because when you sleep prone, your head is fully rotated about 90 degrees. And that's putting your neck in end range rotation, which is probably going to cause you some problems. Conversely to that, you sleep supine. It usually means your head is in a fairly supported position. Your spine, low back, is fairly neutral. And most people don't experience problems there. However, you may get a sore spine to the head if you are a chronic snorer from your partner. And then the other position is side lying. So side lying is an interesting one. When we look at the general sleep literature, side lying accounts for about 60 to 70% of the sleep time that people spend posture-wise. Unfortunately, when we're looking at it from a literature perspective, well, from a practical perspective, it ranges hugely. So side lying can be anything from the so-called recovery position in CPR, where you're sort of trying to save a person who's unconscious from vomiting and ingesting their vomit, to somebody that's sleeping on their side with their knees bent together like a fetal position. And that's what we found was interesting. Only 10% of the time is actually spent in prone, and given that prone is supposed to be the worst position, we were sort of saying to ourselves, well, what's going on in side lying? Because it's the sleeping position which most people spend their time. And some of those positions that they're sleeping in, I would call provocative on the spine. That is, they induce rotation and or extension. And some positions are quite supportive and spinal neutral. So that sort of made us look at that in a lot more detail. And we decided to divide side lying out into two positions, one which was supportive and one which was provocative. And we had to go through a process of doing validity and reliability studies to show that we could actually see that in the home environment under a doona and sheet, often with dogs, cats, and kids. But we found that, yes, we could, and that it was reliable. So that was sort of part of our study, was to divide that out from the standard one position into two and group them as provocative and as to side lying supportive. And because we're looking at provocation of spinal tissues, that really leads us into a little short deviation into the biomechanics. So what we're looking at here is that biomechanics relates to tissues, and we're particularly interested in collagen. And I'm not sure if you're familiar with the old stress strain graph from, that first year of physio and probably the first year of osteopathy as well, where we looked at the effect of a progressive load, and we had the toe phase in which the crimp of the collagen was uncrimped. We went into the linear or the elastic phase where the tissue was lengthened as the tissue got more resistance applied to it. Went into the plastic phase, which is where the tissue started to deform and bonds were broken, and then finally into the phase where it actually ruptured. So that's the stress strain graph. And most people, we're talking about 3% elongation is occurring in that toe phase. And it's in around that phase that tissue starts to become damaged, and initiation of the release of prostaglandins and other sort of signaling and indicated chemicals that tissue has taken place. So that's the stress strain graph. And the toe phase is sort of that little toe phase, increases in tissue length, but not much in regards to tissue stress. Once we get past the 3% elongation, we start to get tissue damage, and that's where we move into the elastic phase. And then once we go from elastic to plastic, we get failure. So that's, you think about your acute ankle sprain, it's gone from that toe to the elastic to the plastic and to rupture. The other common thing that we talk about in biomechanics is the hysteresis curve. And that particularly looks at the loading and then the unloading of collagenous tissue, and that the tissue doesn't return to the same point. And that's because bonds are being damaged, heat's been expended, and the tissue takes a period of time to come back to the baseline. The difference between the loading and the unloading phase is called a set, and there is a varying period of time depending upon how long it takes to come back to the set. With increasing age, it takes longer. With people that have hypermobility syndrome, it takes longer. And people that have previous injuries, it also takes longer as well. So not everyone is the same, and it's just we need to consider that with our clinical situations. When we look at sort of what's happening with regards to tissues in regards to elongation, which is what's happening at nighttime, that's why it's relevant to what we're looking at here. When we look at feline studies, they subjected them to 10 minutes of a low load, so about 20 Newton meters, and they followed up with 10 minutes of rest, so equal load rest period. And they repeated it 6 times. So they looked at that repeated hysteresis process as well. And they found that it took 7 hours to recover the normal length. So getting back to a normal set to recover the normal resistance of the tissue to further loading. On those repeated on-off loading periods, they noted muscle spasms in the cats. And following dissection of the spinal ligaments that were stressed, they noticed there was a significant increase in the range of the pro-inflammatory chemicals that we would expect to see, indicating inflammation and tissue damage. Now, that's the sort of the key points. And 10 minutes on, 10 minutes off, 6 cycles, 7 hours of rest. And they did find at dissection that they had muscle inflammatory indicators, and they had pain and muscle spasm during the process. When we look at human studies, and we didn't go to the final stages, but they did a sustained flexion of the low back for 10 minutes. And they found that these individuals, young, healthy, fit people, so no pathology, they also complained of pain onset and also experienced muscle spasms. We'd assume that if we did do ligament dissection, we'd probably come across the same thing with regards to inflammatory chemicals. Okay, so what's the relevance of all this stuff? Well, we've discussed biomechanical things as regards to creep and hysteresis, and we're looking at positioning of passive restraining structures and placing them at an end-range position, and what's going to happen to that in the sleep posture. So if we sleep in a position which is not supportive, and we think about provocative side lying or prone, tissues are being forced to the end range, and are looking at those principles of 10 minutes of load and reload, there is that potential for us to have some sort of significant loading on our tissues, and therefore the potential to cause some sort of pain. So it's interesting that when we think about those studies with regards to the animals and the humans, they were all when the subjects were awake. So they had voluntary muscle control. So we need to also consider not only the passive restraints, but also that active system and joint stability. Now, what does that do? So joint stability is influenced by 2 main things. Firstly, movements in the neutral zone, the so-called joint play, that's influenced strongly by gravity. So gravity is one of those things that provides compression on our tissues and provides proximity. So our joint buffers, like our zygapophysis joints, are more in proximity, so they have more resistance. And it also means that that joint play, or the neutral zone, is diminished. Now, the neutral zone is an area where movements in the lumbar and the cervical spine are what are called non-linear. So think about that, the toe phase of our stretch strain graph. When you move a joint around passively, what you're actually feeling is that joint play, or where those collagen fibers are crimping and uncrimping. So you're not applying a lot of resistance, but you're getting a fair amount of movement. And we don't really push into that sort of elastic phase, because that's when you actually get some significant tissue damage. So general passive movements are existing in that sort of toe phase, and we're looking at that creep phase occurring. In the upright world, we have stability provided not only by the compression effect of gravity, but also by muscle contraction. So muscle contraction and gravity give us stability around a functional spinal unit, such as L4-5. And in summary, that basically means that we have these stability systems, muscle, gravity, and approximation, that when we lie down at nighttime, we're going to lose. We're going to lose the compression and gravity, so we're going to have an increased neutral zone. We're going to have a lot less bony support because we've lost that compressive effect that brings our bones into greater proximity. And essentially, we were going to rely a lot more on our passive soft tissue structures, some of which are active, like our muscles, and some of which are passive, like ligaments, joint capsules, intervertebral discs, those types of structures. And of course, we run into another problem there, though, that at nighttime, when we're asleep, basically our muscle system is asleep. So we lose that protective response that we would have during the day. So a little bit of a diversion, but we can actually measure this. So when someone has a burst fracture of their vertebral body, one thing that they do is they replace the vertebral body with an artificial vertebral body. And for the point of this study, they actually included some telemetrized implants, and that enabled them to measure a lot of load through the vertebral segment under different circumstances. Now, for the point of this conversation, we're really only interested in changes of sleep position. So the data was looking at supine to side lying, sideline to sideline, and sideline to prone. And what they found was that if the person was preempted to say, draw your stomach muscles in, develop an isometric contraction, then there was like a 200% reduction in the load in comparison that if they just said, just roll over. So muscle support, even if it's just isometric, provides a huge amount of protection to our spinal segments, which for us, flip that round, means that if they're not activating their spinal segments, or the spinal segments aren't being supported by muscle contraction, even greater load is being borne by the passive restraints. Again, the ligaments, the joint capsules, the intervertebral discs. So unfortunately, when we're asleep, given that only our eyeballs, diaphragm, and heart are the only muscles that are pretty much working when we are sleeping, we don't have a muscle support system to give us that protection that we would normally have if we were awake. So in summary, the biomechanics of sleep, the relevance to us is when we are asleep, there's less compression because we're lying down, there's less bony support because there's less gravity, and there's less muscle protection because basically we're asleep, and that all results in our joint segments have a greater amount of play. The greater amount of play is going to mean there's a greater load on our passive restraints because our active ones are gone. But we also have to consider past injuries, because that's going to mean there's going to be greater or less quality tissue, and also people with hypermobility. And this is something I've found myself clinically, that people that have, what I would call provocative sleep positions tend to suffer a lot more in regards to if they have a positive Brighton's or Baton's hypermobility scales. And that we know from those feline and human studies that collagen is susceptible to sustained or repeated low load. So it doesn't have to be high load. Either or is going to cause some degree of damage in regards to those passive restraints. And that's going to result in pain, as we know, muscle spasm, and probably the release of pro-inflammatory chemicals. The body responds to that when we wake up, and think about what you sort of see with the acute corticolis, but also with regards to those low backs. It's the muscles that tighten up. Often there's not tissue damage as such, but the person has restricted range of motion. That is what's limiting their overall functional capacity along with the pain. So that's the sort of the biomechanical relevance. And look, I know that that's probably some of it's relevant to you and some of you understand, and some may be a bit different, which is cool. What I did was I put together, because you've got to, I sort of find that because my research question arose from clinical information, and one of the biggest things about research is translating research to clinical findings. I put together this 14-day sleep posture challenge. So basically, I believe if you experience something, it means you're going to understand it better. So I'd encourage you, if you want to learn a bit more about this, it's a free challenge. It's just a bit of fun. For 14 days, you get a couple of emails with regards to how you go about the process. I also include our sleep hygiene guide, which comes from our sleep mastery course. And because it's the second most popular topic is mattresses and pillow selection, I included an email about that as well. And I've included a video, which is actually my exact conversation I have with patients on educating them on how to change their sleep posture. So you get all that. It's a bit of fun, and you'll also have the experience of what it's like to go through that process of changing your sleep position. So you're welcome to sign up for that and have some fun. And also in the process, learn about how you can educate, if not yourself, and then you change sleep position, then I'll give you a direct idea about how you can go about it with your patients when they present with that sort of waking morning pain and stiffness. Alrighty. We'll go back to our case studies, but does anyone got any questions? Like, does anybody have a burning desire or something they want to ask at that point before we move on to our case studies? I'll take that as an authoritative no. There are no burning questions. All right. Case studies. We're looking at Josh, Matthew, and Emma. All right. So the straightforward thing with Josh is that he's a basketball player. He's young. He had an inversion injury. He doesn't get tired until about 11 or 12 o'clock at night. He needs to be up and to catch a school bus by about 7 o'clock. He's having difficulty concentrating and learning at school. There's possible considerations because he's got some poor motor performance and learning is difficult for him post-injury and his recovery phase. So when we think about an inversion injury, we think about a person that's got ligamentous damage. They have to go through a rehab process, and part of that's going to be learning motor skills about how to land properly and balance and retraining and that sort of stuff. So the key things with him are that as part of the rehab as a physio, I'm going to be thinking, well, hang on, how am I going to teach him new skill acquisition? How am I going to encourage injury repair, improvements of his motor performance if he's not getting sufficient sleep? Now, his age group needs 8 to 10 hours of sleep. If he's not tired until 12 o'clock and he's having to get up to catch the school bus by 7, he is not getting the adequate amount of sleep to enable or to optimize his injury healing and also his recovery and his improvement of motor performance. So the thing that he's got, which is what we call his diagnosis, would be inversion injury. That's straightforward, but he's actually experiencing what's called a delayed phase shift disorder. And we are governed by our sleep, which is a circadian rhythm. And traditionally, you'd sort of say people go to bed about 10 o'clock and they get up at 6 o'clock and there's their 8 hours of sleep. Now, teenagers are notorious for having this delayed phase shift disorder, which is they basically don't feel sleepy until about midnight. And if you've had teenagers, you probably know this, and you've tried to get to go to sleep, but literally it's like you as an adult saying to yourself, okay, I normally go to bed at 10 o'clock. Now I've got to go to bed at 8 o'clock. And it's just going against your natural circadian rhythm. So we need to understand that in teenagers that this is a natural thing. It's due to their melatonin release being much later in their circadian rhythm shift. And we can encourage them, we can train them, we can teach them to progressively improve that. But we also need to understand that that's why they need to be, if they're not getting to bed late, they actually need to be getting up late as well to get the adequate sleep to then perform mentally and physically and to repair during the next day. So that's Josh's little overlay. Matt, who is the detective with chronic plantar fasciitis, he's an adult, so he needs about 7 to 8 hours of sleep. He works shift work, which is basically means you've got your regular hours and has significantly high stress levels. He has adopted some habits to get him to get through the day, which involves both napping during the day and using coffee to stay awake. So he uses naps to catch up and coffee to stay awake. He's also taken on the habit of using alcohol in the evening to relax him. His issue is that the chronic plantar fasciitis is not healing very well. He's noticing that he's slow to recover, and this is actually due to his limited and or broken sleep. He's also trying to conceive his first child for the past couple of years, and he's had tests and he's found out he's actually got very low sperm numbers and sperm motility. So we would look at Matt and sort of say, look, you've got your chronic plantar fasciitis, which is partly probably chronic because your sleep system is so disrupted. You've got what's called secondary insomnia, which is due to the anxiety. So he's having trouble getting to sleep and staying asleep. And he's also then started to take on some primary insomnia problems where he's actually affecting his sleep cycle through taking naps. So he's reducing what's called his sleep drive. And he's also using some coffee, which is actually going to kill his melatonin production, which is what we need to start that sleep orchestra in the evening. So he's got a diagnosis of secondary insomnia due to anxiety, but he's also got some primary insomnia issues as well. that I would believe you would need to address if you wanted to really address his chronic plantar fasciitis. And Emma was our third case study. She was a young mum with 3 young kids. She was wanting to increase her fitness and lose a few kilos into the bargain. Her requirement, like Matt, 7 to 8 hours. Her issues are she has trouble falling asleep within 30 minutes. So 30 minutes is a bit of a, I guess, a hallmark that if people sort of say to you, I sort of, toss and turn for an hour or so before I get to sleep, they've got what's called sleep onset insomnia. So it's a particular type of insomnia. But then she has this other issues where she's waking several times, one for toileting. So she has a stress incontinence or urge incontinence in regards to her bladder function, and all the children are waking her up for different demands as well. So the result of that is she's feeling tired during the day. And if we're trying to get her to exercise, and she just, you don't feel motivated to exercise if you're feeling tired. So for her to increase her fitness, we need to address the sleep for that reason. But also because of her short sleeping or her disrupted fragmented sleep, she's actually got another issue where she's making some poor food choices. And the types of food and the quantities that she's consuming is not really ideal for her to achieve what she's after, which is weight loss. So she's being affected in a double whammy for both of her goals by that short sleeping. So we diagnose her as having secondary insomnia due to anxiety, so a bit like Matt had it, but she's also got a bladder insufficiency. So we would need to, as physios, educate her, do a urine diary, and educate her on normal voiding and how she could then improve that capacity so that she only needs to go to the toilet, say, once a night, which would be considered probably okay for a person of her age and having had 3 kids. So there are 3 case studies, and we'll come back to those 3 with how we're going to manage them in that management section. But this is just something to consider with regards to, is dealing with these sleep issues within our scope of practice? And I'd like to flip that question around and sort of saying, perhaps we should be asking ourselves, does the public expect us to be providing some sort of advice in this area? And there was a survey done in 2019, which was looking at not just sleep, but a whole range of therapies that are provided by physios. And I'm not sure if there's anything similar being done for osteopaths, but I would imagine the overlay is probably pretty quite the same. And they surveyed people in the public, and they sort of said, look, with regards to providing sleep advice, how important do you think it is that physios provide this advice to you? And 60% of the respondents believe that it was extremely important or important that physios provide advice on sleep. Now, this belief of the respondents was greater than that we should be providing advice about weight loss, giving up smoking, eating healthy, provision of acupuncture, manipulation, or hot cold therapy. So they're things physios do fairly routinely, really. And yet the public believed that this importance about sleep was more important than these other things that we as physios would consider something we would do routinely. And then they were asked, well, how likely do you think it is that your physiotherapist would be providing you with this type of education? And less than 50% thought it extremely likely or likely. So essentially the public is expecting physios to provide this advice, but they don't believe that physios will or can provide this advice. So to me, that's like an opportunity to upskill and provide something that physios are expected to provide and can quite easily provide, because we have that sort of environment in which we can provide that type of education. So I'm not sure whether it'd be the same for osteopaths, but I'm guessing it is. So the public is asking for it, but we're not providing it as well as we could do. Okay, so objectively, here we are in our clinical situation, and it's kind of like saying, well, what do we do to screen for these things? So maybe when we get to the conversational part of this presentation, you can show me or explain to me what you guys would do to screen, because I think it was about 60% of people said they're doing this already. So my first question is, do you have trouble getting to sleep, staying asleep, or waking up too early? So that's question number 1. And that leads me into, so that's the subjective. The objective is to get them to do a HADS questionnaire. So anxiety and depression questionnaire, very easy to do. And it gives you a pretty prompt response as to whether that person has got some clinical indication of anxiety or depression. The second question is, do you wake feeling tired or experience daytime sleepiness? Now, remember, one of the side effects of short sleeping was death. And the number one reason for death in that situation is people involved in motor accidents due to daytime sleepiness. So if they sort of say, yeah, I feel a bit tired, or I don't have any energy and I've been in bed for 10 hours, 11 hours, then one of the main things we're looking at there is sleep apnea. And you can do the stop and questionnaire, again, very simple. And that will point quite clearly to whether a person is experiencing sleep apnea. And we can do something for those people and or refer them on for sleep studies. And then the one which is the mechanical type process, mechanical based question, which is around my research, is your neck and or back pain better or worse in the morning? So for those people that answer, yeah, I guess it is a bit stiff. You know, it doesn't happen every morning. That's probably something to just clarify. Our research looked at 3 to 4 mornings or more a month. So about 1 or 2 a week was significant from our study group. So it doesn't have to be every morning. And that's something probably a trap not to fall into. So then that leads into, well, how old is your mattress and pillow? Mattresses at a sort of 7 or 8 years are basically on their way out. Pillows 2 or 3 years are on their way out. And then I'd also be asking, what positions do you think you sleep in? So I'm really nailing the person on that. Like, where's your leg, top leg, where's your bottom leg? How long do you think you spend in that position when you wake up at nighttime? What position are you in? People often would look at you and go, oh, geez, I don't really know. So that's fine. I say, that's fine. What I want you to do the next couple of nights before you come back is just take a closer eye to what you do when you wake up in the morning, during the night, what position you sleep in, because it's quite important. So that's the screening sort of stuff that I do. The validated sleep specific things that we can utilize are a sleep diary. This is very useful. The sleep diary is going to give you things like when they go to bed, how long they take to get to sleep, how many times they wake up during the nights, what woke them, how long did it take to get back to sleep, and often just rate 0 to 5 your quality of your sleep the previous night. So they just have a standard, little A4 sheet, Monday to Friday, and they just write those things down. And try and get it done over 2 weeks, because they might have had a big Friday night, Saturday night, which might skew the results. But you just want to get an idea for that particular person over the course of the average weeknight and weekend nights, what's their sleep profile, because that's going to very much to lead you into how you're going to intervene, what interventions you're going to provide them with. The Insomnia Sleep Index is one of 2 very commonly used questionnaires in the research. And that classifies people into having insomnia as being not significant, subthreshold, moderate, and severe. When you do intervention, then of course you can reapply the Insomnia Sleep Index and see the effects of your sleep interventions. The other one is the Pittsburgh Sleep Quality Index. It takes a bit longer to complete. It can be a bit of a pain because it does take longer. The benefit is that it classifies people as a good sleeper or a poor sleeper. And you can also go through the different components of it, and it breaks down as to probably some indications as to where that person is having issues with their sleep. So it's a bit detailed, but it gives you a bit more information. You just have to work out. So we do these as onboarding questionnaires. So when somebody or it sort of applies for an appointment to do with sleep, we get them to do these things as part of their onboarding process. So before they get to the practitioner, they've already completed these questionnaires, so it doesn't take time, but we've got the information straight away. Okay, so then we get them into the room, and clinical tests specific to the sleep, I get them to demonstrate their sleep position. Now, if they say, oh, I think I do this, I think I do that, I say, okay, just show me that, but tonight, next couple of nights, I want you to really think about it, and then we'll go over it. Because some people are very light sleepers, and they're very aware of the position they sleep in. Some people have no idea what position they sleep in, so they've got to really think about it. I like to assess their cervical range, because if they do have a cervical, if that's the main problem, then what we tend to find is their cervical range is limited. Okay, so if the direction is limited, so the direction of limitation often reflects the side of their preferred sleeping position. So if they like to sleep on their left side, and they're basically rolling into a prone position, their body is rolling towards the left and the head is being forcibly left in right rotation. And that basically what that means is their neck is spending more time in right rotation, and they're going to have trouble through protective spasm turning to the left. So if they've got a very obvious rotation loss, say in the left, that almost tells me they're probably sleeping provocative side lying on their left side. So that's just a little bit of an indicator to consider. And the other one is what I call the cervical sleep stress test. And I'm not sure, can you see this? Is that video playing? Someone? All right, so you can't hear it, but what I'll do is I'll talk over it and explain what's going on. And then if you've got questions, we can go from there. So the cervical stress test is just something, it's not validated. It's just something that I've noticed with patients. What I'm doing is paraspinal palpation around the mid-cervical spine, thumb and index. And I just wobble the neck into side flexion. And what I'm particularly looking for is what degree of reactive spasm am I palpating through my fingers in that mid-cervical spine. So about C3, C4, C5 is where I find it particularly interesting. Now, when a person has just an acute neck problem, they usually are segmentally sore over one level and usually one side. What I tend to find is if somebody has a provocative sleep position that dominates, you tend to find the whole mid-cervical spine is thickened or reactive, what is basically probably protective spasm. So that's what I'm looking for, is the difference between, is it single segment, multi-segment, unilateral or bilateral. The other test that I use that I find quite interesting is that people that sleep in a sideline position provocative, they're also sore over their superior aspect of ribs 2, 3, and 4. So I just do a gentle protraction, retraction shake of the shoulder, and I'm just having a feel on those 3 points where the serratus posterior superior muscle attaches, and either feeling stiffness and or getting a pain response from the patient. And again, if I find they're sore, that to me is a strong indication that the patient is sleeping in a provocative sideline position, and that will be contributing in part to that person's symptomology. And that's why I find those two things clinically clear. If they're clear, then the sleep position is invariably not relevant. So it's a cervical sleep test through side flexion, and then the serratus posterior stress test through protraction, retraction of the shoulder girdle, just to palpate the point of origin of serratus posterior superior on ribs 2, 3, and 4. All right, so then we get to what can we offer? So we return to our 3 case studies. And the first thing that we can offer is education. So we're talking about getting people to change habits. And as you would probably know, changing a habit is not an easy gig. We need to give some degree of reasons as to why they've come to you for pain. So we can relate the pain back to the sleep posture. That's going to give them some degree of motivation. So education usually revolves around teaching them about the sleep cycle. And there are 2 key things. One is that we have a thing called the sleep drive or the sleep debt, which basically means that the longer you stay awake, the more tired you become. And that sounds logical, but it's actually due to a chemical or hormone called adenosine. And adenosine is built up by staying awake, and it's got rid of by going to sleep. So if you have a nap during the day like Matt was having, that's going to reduce his sleep debt and make it more difficult for him to get to sleep. It's also killed by caffeine. So him having coffees is also actually going to restrict and affect the effectiveness of that natural sleep cycle. The other chemical that's key to the sleep cycle of alertness is melatonin. And melatonin is produced as the light goes down. So if you're out camping and the sun's settling down, your melatonin production's in full swing. But if you're at home and you're under bright lights, blue lights, watching your iPad, catching a movie, Facebook scrolling, you're actually going to have that melatonin production reduced. Melatonin is also reduced by cortisol. So if you're stressed, that's also going to reduce your melatonin production. So those 2 chemicals, adenosine and melatonin, work together so that around about 9 o'clock, 10 o'clock, you're starting to feel drowsy. You are maximally wanting to go to sleep, and that's why you fall asleep. Conversely, if those 2 chemicals are affected or reduced, or the cycle is out of kilter, then you're not going to get the double benefit and find it easy to fall asleep. There's another little peak of drowsiness around that 3 or 4, 2 or 3 o'clock, 3 or 4 o'clock in the afternoon, a siesta. And that's what you have to be aware of. Some people do nap then, but if they're having issues getting to sleep at 10 o'clock, we need to knock out those naps because it's reducing their sleep drive and it's affecting their ability to initiate sleep. So we need to educate people about the sleep cycle and the natural processes involved in that. Another one is also involving sleep hygiene. So sleep hygiene is really just talking about factors that aren't physical, mental, or environmental that are affecting their sleep cycle. And there's a whole bunch of those there. And actually, when you do that 14-day sleep posture challenge, you get that sent to you. So there's 16 points there to do a day and night sleep hygiene factors to take into consideration. And I'll give that to all of my patients and say, look, just have a read through this and let me know if any of these strike a chord with you. And then that initiates a discussion as to what we need to talk about. So it can be cigarettes, it can be alcohol, coffee, kids, getting up to the bed, getting up to the toilet too often. A lot of different things can really disrupt that natural sleep cycle. And we need to get on top of all those. So that's common across those 3 case studies and common across basically all patients that I would see. So what can we offer in the specifics? Okay, so when we look at young Josh, we know he needs 8 to 10 hours. We know he's getting up at 7 o'clock and he's going to bed at midnight. So he's not getting his 8 to 10 hours. So he's got what's called delayed phase shift disorder. He'll grow out of it. So usually the majority of kids by hitting the early adults around 20, 22, 23, they will actually, their phase shift disorder will go backwards in time and they'll start to get drowsy by 10 o'clock. But at the moment, he's not there. So we can use something called cognitive behavioral therapy for insomnia. So you probably had a CBT for pain. It's the same sort of concept, but we do it for insomnia. And we sort of structure their sleep-wake cycle around getting up at a fixed time in the morning. So he has to get up to get ready for school. We know that's fixed. And what we want to do is we want to shut off his melatonin system very quickly. So bright light, bit of exercise. What it's really doing is it's bringing his cortisol levels in and up, and it's shutting down his melatonin. So he's going to wake up, and what we aim to do is we get him to go to bed just 15 minutes earlier. So he's going to gradually work towards getting his 8 to 10 hours of sleep, keeping his same wake time, making it abrupt and get rid of the melatonin in the system. And he's going to build up a little bit more sleep debt. So when he comes to the next night of sleep, he's going to feel a bit tireder. So he's going to go to sleep a bit earlier. And pretty much we go through the CBTI and bring his sleep cycle forward in time so that he can achieve his natural 8 to 10 hours of sleep. And that means all those things that he was having problems with is going to be improved. Matt, he was having issues with stress. So he had that secondary insomnia due to anxiety. So we need to educate him about how stress causes a cortisol, the hypothalamus pituitary adrenal gland system. We need to educate him about that sort of adrenaline release, cortisol release, and that's having issues getting him to go to sleep. We need to teach him how to deal with his stress during the day. So we talk about deal with the stress during the day. So exercise, breathing exercises, mindfulness. He might do a thought diary. He needs to be aware of those things. So he deals with the stress during the day so that he doesn't take it to bed at nighttime with him. It's important for him to understand that alcohol is not really a sedative. It's actually high in calories. So it might make him feel a little bit more relaxed, but unfortunately that calorie rebound causes something called sleep rebound insomnia, which means about 3 to 4 hours. Once your body's consumed the calories, your body looks around for more of it and it wakes you up. So alcohol to get to sleep is not a good idea because of that rebound insomnia. Caffeine has an effect that it takes sort of between 6 to 8 hours for 50% of it to be out of your system. So if he's having coffees after lunch to keep him awake, he's actually also having problems going to initiate his sleep. Remember, caffeine knocks out your melatonin, so his natural sleep hormone that's going to make him feel sleepy. He's being depressed. So he's got to really say no coffees after lunch. So it's giving plenty of time for that caffeine pretty much to get out of his body and not affect his normal natural melatonin cycle production. Cigarettes are another stimulant. The nicotine is a stimulant. It doesn't last as long as coffee. It's only about 3 or 4 hours, but we sort of encourage people to not have your cigarettes after dinner. So again, the caffeine's had a chance to get out of their system, and we need to educate him also about the napping. So he thinks the napping is getting him through the day, but it's reducing his natural sleep drive. So his adenosine is taking a hit, and that's what's important to get in to fall asleep in concert with his melatonin. So he needs to understand a lot about the sleep cycle and also deal with his stress so he can start to normalize his sleep patterns. And then we looked and had a chat to Emma about her stress. So she was having different stresses during the day, and also needed to understand that link between the chemical cascade of stress and how it affects getting initiation of sleep and also maintaining sleep. She was having some issues getting up a few times a night to go to the toilet. So as physios, we would put on the real-time ultrasound and we'd show her her bladder function, and we talk to her about pelvic floor strengthening and how she can do that. We'd get her to do a urine diary so we could demonstrate that she can hold a capacity up to 200 to 300 mils. She needs to retrain her bladder to get used to being distended. So she needs to learn to ignore that early signal of, I need to go to the toilet. So she can build up a capacity. So during the night, she only needs to get up once during the night. So there's a process there that we would go through with any lady that's having sort of urinary problems during the nighttime or even during the day. We need to educate her also about short sleeping having effect on her natural eating habits. This is kind of an interesting, that hormones do regulate our urge to eat, and they revolve around two ones. One's called leptin, which gives us a sense of being full, and ghrelin, which makes us feel hungry. So the research has shown us that just after one night of short sleeping, your leptin, which is the one that makes you feel full, goes down by about 18%. And I call it the guzzling ghrelin, that goes up by about 30%. So just one night of sleep means that you're going to be more inclined to eat chips and nuts and pasta and bread and potatoes and cakes and all that sort of stuff. Not because you need it in a calorie reason, but just because your hormones are telling you that you need to eat it because you've short slept. And there's a double whammy. Our cannabinoid system, our reward system interacts with that, and we get releases of dopamine and opioids as a result of eating. So it's kind of like a reward system, which is rewarding what we don't want to be rewarding as clinicians. So short sleeping is going to make it difficult for Emma to lose weight as well until we get her onto a normal sleep process. And then she would need to be sort of just being educated on what's an achievable exercise program. So starting with walking, doing some home weights, Pilates, find out what she likes. So going through that process of designing up an exercise program that she can achieve and enjoys, so she'll stick with it and be consistent about it. Okay, so I think some of the things that we've covered there, you will be, really clear about. Some of the things perhaps are not, and that's what I found with the physios that I talk to. They sort of say, well, I can understand the relevance, and clinically I see those types of patients, but I don't have a grasp on all those concepts. So we have available it's called the Sleep Mastery course, and it's an online one, which is an evergreen. So you can either just do it at your own time, own pace. Some people want a bit more interaction. So we do a cohort course as well, where you basically sign up, and for a 6-week period, we go through, we have Zoom meetings, talk it over, and we go through the presentation. So it's a bit more interactive, I guess, with both myself and with other colleagues. But those two things are available. And if you're interested, we can, I can give you some information about those. So that brings us to the end of this presentation. I really do want to thank you very much, both for your attention and your attendance. I know it's late over there and you've probably got things to do midweek, so very much appreciated. And just ask you if you've got any questions, I'd be happy to try and answer them.
If anyone has any questions, you can unmute your microphone and ask Doug.
Doug, Kevin Williams speaking. And
Hi, Kevin.
I've got my two children trying to disturb me at the moment, knocking on the door. Sorry about that. I feel like the...
It's all right.
Children, I'll be there soon. Can you just give me a moment, please?
Bedtime story soon.
So can you assess whether I'm telling my patients the correct advice? I tell my patients the two best sleeping postures would either be to sleep on your back and to try to minimize the small of the back in order to reduce that stress on the collagen fibrils. But most people sleep on their side, so I suggest to them that they have an appropriate height pillow such that the axial spine is completely linear from the cranium right through to the sacrum. And I tell them to pull their arms through so that their body weight is being borne by the base of the scapula, and to avoid having their shoulders perpendicular to the sleeping surface, because that could maybe compress the first rib into the clavicle. What do you think to the advice I'm giving to my patients? Should it be modified?
Yeah, look, and the probably the easiest thing to do with that, Kevin, is go and do the 14-day sleep challenge, because that goes through the whys and the whats, and it also goes through like a specific explanation of this is what I say to patients. And that's based upon our research of sleep posture. So the intervention that we have in that challenge is exactly what we did in our longitudinal study for patients with neck and back pain. So probably
looking at that diagram there, I mean, the supported side.
Correct. I've gone to that. So supine, and so generally supine is considered stable and safe for most people. So that's one. You don't need to have a pillow under the knees or anything like that for the low back. If they have acute low back pain, then you need to modify. But we're talking about people that have intermittent back pain in the morning, and or you think have limited range of motion because of stiffness, and you suspect there's an underlying thing and you're suspecting it's a low back due to their sleep posture. So supine, yes, supine is fine for most people. The side lying and prone is obviously not a good suggestion. So we'll get to those two to start with. The research that we looked at was side lying was probably the biggest area. And in fact, we're in the process of publishing our final longitudinal study. So I'll give you the gist of that. When we asked people to change sleep position, as I demonstrated in that video in the 14-day sleep posture challenge, what we found was that their prone and their supine time didn't really change, which I found interesting because I thought they'd get less time in prone and more time in supine. What we actually found that they changed in the most case was they got out of provocative side lying, where the top leg is rolled forward, and they got back more into supported side lying, where the top knee is slightly behind the bottom knee. Does that make sense?
Yeah, and that looking at that supported side lying, that individual is doing exactly what I'm asking my patients to do, where she pulls her shoulder forward and she's resting her body weight on the scapula.
Yeah, so the top arm, so if they've got low back pain, I don't talk much about the top arm because it's more to do with the body weight coming through the hips. But I talk about, I'm not sure if you can see my cursor, is that moving on your pictures?
Yes. Mm-hmm.
Yep. So that top knee is slightly behind. I sort of say, rest your top foot in the arch of the bottom foot. And that gives them a muscle memory position to think about. And that's controlling the weight of their top limb. If they have low back problems, that's what I focus on. If they have neck problems, and I call that block point number 1, and I call this one block point number 2. So what's happening there is that they're forming a triangle, which is the strongest shape in design features. And they just rest their anterior glenohumeral joint against their hand, and that forms a triangle, and that stops their trunk going forward. And they seem to find that's pretty helpful for people with neck pain, in addition to block point number 1. And because we're falling asleep and because we're in side lying, our center of gravity is high, to try and get some stability between those two block points, I get them to put their hand between their thighs, and that forms like a diagonal crossbar. So if you think about a gate, it's got a hinge and a latch, and a gate has a diagonal stabilizer bar. So I'm a farmer, and so I come back to very practical type things. And when they do that block point 1, block point 2, and then stabilizer bar, they sort of say, yeah, I feel really nice and stable. And remember, when you fall asleep, you don't have that muscle support system. So what it's doing is it's giving you a stable body position, even when you're asleep and your muscle system is asleep. So that's the full package as far as I'm concerned when we're trying to change a person's sleep position. You mentioned about putting a pillow between the knees. Was that what you also said?
Oh no, I was just recommending that they try to avoid too much lumbar extension in supine position.
Yeah.
To try to minimize the amount of lumbar extension in the supine. I just have one quick follow-up question. I often get asked by patients about the choice of pillows. So, yeah.
Another discussion. Again, it is in that sleep posture challenge. I go through a whole email about pillow selection and why and what, but yep, ask your question.
Oh, well, I just personally, I think that so long as you've got a good linear formation down the axial spine, that's the best you can achieve in terms of the choice of pillow. I personally like the I can't remember now. It's a type of synthetic material which never changes its shape, so the head doesn't sag into the pillow.
Concrete?
I can't remember it now. Super latex pillow. That's it. Super latex. Yeah.
Right. So latex is a rubber, so it's a natural substance, and some people like it because it is natural. You just got to be careful though. There is some cheap stuff out there it's called something latex. I'm not sure if it's super latex, but it's actually not true latex. It's actually a synthetic. But yeah, latex by itself is a rubber product, and people like it because of that. But look, memory foam, it comes down to probably just have something like you're saying, which keeps your spine in decent alignment. The issues are don't use feather because there's not enough support. If you're a supine sleeper, you probably need a lesser pillow in height. If you're a side-lying sleeper, and particularly if you're a bloke, you're going to need a thicker pillow because the distance between the bed and your shoulder is increased, head to shoulder different distance. But you've also got to realize that you've got to take the bed into consideration. So if you have a soft bed, you're going to sink further into the bed. And that's why I like to talk about the whole thing, the whole system together. If you sink into the bed more, you're going to need less height to support your head. If you have a medium firm or firm bed, you're going to sit proud on the bed. So you're going to need a higher pillow. So we've got to match up the pillow with the mattress. It's not one or the other. But interestingly enough, the research tends to say, and I would agree, clinically, change your sleep position before you start delving into the sleep system. The sleep posture is more important. Then if you fine tuning that and it's good and they're still having issues, then you'd probably look at discussions about mattress and pillow.
Thank you.
You're very welcome. Thanks for joining us. Enjoy your kids.
Yes.
Doug.
Yes.
Hi, Doug. I'm
Rob.
Rob. Can I just ask a quick question? So in your survey, when you were asking if we ask routinely about sleep quantity, quality, position of sleep, I do that. But I also found that the question I ask everyone is what are you doing in the last hour and a half before you go to sleep? Because I find that most people, if they've done all their homework or chores or washing up or put the kids to bed, then they usually deem that period to be, a relaxation period. People are either watching television or watching a film, Netflix, or reading or on the laptop, but it's usually a sustained and suboptimal position that they're in. And so when you were saying that they wake up in the morning with back pain for no particular reason, I often find that people are not linking those two things because it seems innocuous and not related to their low back pain. But I was just flagging that whilst sleep position is of course hugely important for that collagen creep and hysteresis, but their position, if for about an hour and a half prior to going to bed, could well be the thing that triggered off a low grade inflammation overnight.
Yeah, so that's a good question, Rob, and there are lots of answers to it. So I'm not sure if I'll try and categorize them. So if the person is elderly and they tend to have a stiffness problem in general, I would, draw their attention to the fact that a lot of their underlying problem is due to a lack of mobility, full stop. And if they want to get 7 hours sleep at night, which is static activity, it's really important that they don't then spend 2 hours sitting down watching the telly before they go to bed. So does that make sense?
Yeah.
So I'd be encouraging that person to say to themselves, okay, if I'm going to watch telly, I'm going to do it on an exercise bike, or every time an advert comes on, I stand behind the couch and walk on the spot and do some just gentle stretches. But I'm going to address the fact that my body, because it's old, only tolerates 7 or 8 hours or 6 or 7 hours of staticness. And I can't get rid of 2 of those hours by sitting in front of a telly. It's a bit like when we go camping, you always get up early because you're not comfortable. And that's what their body is saying. So if it's an older person, I would tend to say, look, realize that static is not so good. We need you to spend most of your static time in bed getting quality sleep. It's been compromised by static time before we go to bed. Let's make that a more active period of time. Right. And if it's that sort of person that actually wakes at 2 o'clock and they say, oh, I just feel really uncomfortable and I toss and turn for the next 2 or 3 hours, I actually say, look, it's because of that static stiffness. Get out of bed, walk around, do some gentle stretches, do 10 or 15 minutes of that, and then go back to bed. And they often sleep better because they've sort of loosened up that stiffness that they've got in their body as a general thing. So that's the older person. The younger person who basically they should be out. So, all right, so if they're watching telly, all that sort of computer stuff, that then starts to move into that problem of melatonin production. And if they're having trouble getting to sleep, then that needs to be addressed in that particular clinical population. Unlike, I'm different in the sense that I know I can work on the computer till 10:30 at night, and I'll go into the bedroom and I'll be asleep in 15 minutes. So the blue light, the bright light, that doesn't affect my sleep production. So I don't have a problem with it. But if a person's coming to me saying, I have trouble getting to sleep or, within 15 minutes, then I would start to say, okay, what are you doing the hour before? What are you doing the 2 hours before? So you kind of target your intervention to when they have the problem. If they don't have a problem getting asleep, then I wouldn't worry too much about the bright lights, because most likely it's not affecting their initiation of sleep for whatever reason. Unless they say they have really weird dreams and maybe it's to do with the violence on the TV, or that they're sort of seeing some emotional stuff that their brain's still trying to process. So different groups of people, you got to kind of try and work out, well, when is their problem and is this stuff feeding into that? So if it's a young person and they get to sleep okay, but then they're sort of saying, I do wake up in the morning, I would be very querying about their sleep posture, because nighttime, even if you're a bit stiff at nighttime going to bed from sitting down, you should feel better in the morning. If they're not feeling better in the morning, then I would still strongly suspect their sleep position.
So that includes the, young 20-year-old that is lying on their bed with straight legs and with their laptop on their lap. So, they're in a real C-shaped position, or even on the sofa with their feet on the coffee table. That particular sustained lumbar flexion or whole spine flexion thing may be innocuous at the time, but then but you would sort of say that it's the sleep that would still be the more predominant factor.
I would still correct them about their sleep posture. Their sitting position, because obviously if they're doing that during the night, they're going to be during the day. So they need to be educated on the benefits of having a healthy spine, and what they're doing is not going to help that. But yes, I would suspect that they are still sleeping in a less than optimal position, and that's preventing them from recovering from what they're doing during the day. Interestingly enough, I tend to sort of say, if you wake up in the morning feeling reasonable, sleep position is not a problem. And if they are waking up stiff and sore in the morning, then I address the sleep position first. And then I can say, look, now at least we have a baseline where you're waking up feeling good. If you still have pain and it's occurring during the day, right, now we can start to be specific about what it is you might be doing during the day that you think is normal, but in fact is not for your spine. So I like to use the morning as a start point, because basically nighttime is rest and recovery. If you're not getting rest and recovery during the night, it's usually indicative of what you've done during the night. So I would tend to start there, and people understand that if they wake up feeling good, then nighttime is not an issue. Forget it, move on to their daytime postures, their habits and that sort of stuff. But if they're getting sore in the morning, or they're sore in the morning, then I would strongly suspect that they're not getting recovery, and that would probably indicate either sleep position or their sleep system.
Okay. Thank you.
And that's just my clinical experience. So it doesn't necessarily mean it's right, but that's just the way I tend to process that type of patient presentation.
And the osteoarthritic patients that wake up with a degree of inflammation because they haven't moved for a while, typically 15 minutes to half an hour in the morning, are they still in the same camp? Because it's not always rest.
So again, you're trying to optimize their sleep posture, because that's what we're trying to do, is optimize that efficiency. I had a guy that came in today who's got terrible kyphosis, and this is an extreme example, so I don't take it as being like a normal thing, but I just thought about it today. He's a guy that is in his mid to late 80s. He's got a fair degree of kyphosis fixed. He came in and said, look, I'm waking up in the morning stiff and sore. He really likes manual therapy. He just loves being mobs and massage and just loosen up. It makes him feel fantastic. And he has this problem. He can't stay in bed for more than 6 hours before he just stiffens right up. And he knows when he gets up and moves around, he's going to get better. So I said, look, why don't you try to get your 6 hours or 7 hours, which is what we're trying to aim for. Just have a half hour, an hour nap during the day. And if you can still maintain your 6 hours at nighttime, now we're getting our 7 hours, but you're not staying as long in bed at nighttime in one big chunk. So he's going to go away and try that for a couple of weeks, just to see, can we get up to 7 hours? We know you can't do it in one block, but let's try a nap during the day and see, as long as it doesn't affect your initiation of sleep at nighttime, that might be a way that he can manage his stiffness arthritis, get 7 hours, but not take it all in one block at nighttime. So does that make sense?
Yeah, good idea.
Yeah, so it's kind of just clinically playing around with what we've given, but understanding that sleep posture and the bed is going to be important, but sometimes we have to bend the rules a bit to try to achieve that optimal. But yeah, people with arthritis, let's say person that's had a total knee replacement, it's the same thing. They can't stay still for 2 hours. Their knee just throbs. So they've got to say, like, okay, that's normal. That'll settle down once those pro-inflammatory chemicals are reabsorbed back into your knee joint and that sort of sensitivity drops off. You'll sleep longer. Don't worry about it. But for the moment, you might just need to swing around out of bed, do 2 or 3 minutes of knee board work, knee bending on a skateboard. That'll get the movement. That'll get that sort of pain suppression through descending inhibitory control system activated. Swing around, go back to bed and go to sleep, as opposed to just tossing and turning in bed and not getting comfortable. And for people, that can be a real light bulb moment. So that's fine. I'll get up. I'll just do my exercises. I'll go back to sleep, and then know they don't need to worry about it. It'll just happen.
Mm-hmm. It's the quickest of questions. So for that nap, which I know you don't generally advocate because it reduces sleep drive, but for the nap during the day, do you think that there is a cap on that at 20 minutes or whatever it is, so that you don't go too deeply into REM sleep?
Yeah, basically we talk about 90-minute sleep cycles where you go through stage 1, stage 2, stage 3, stage 4, and come back up to REM sleep. So they sort of say around 20 minutes. That's what's happening there is you're not getting into that stage 3 and stage 4 deep sleep. And that's the one that when you get woken up by an alarm and you're just completely disorientated for half an hour or an hour, that's because you're in stage 3 or stage 4 deep sleep. And you don't want to come out of that quickly. So yeah, if you're having a nap, they sort of recommend 20 minutes, 30 minutes max, because that's when you're going to start to move into that deep sleep and be very difficult for your brain to come back out of that quickly. And it's really leaves you feeling washed out. So yeah, that would be a rough. Now you got to remember that that's a generalization. Everyone's going to be different. Like I know people that can, like we've got farmers here that they'll literally take a 40-minute nap between shearing, break, lunch, and go back shearing again. And they can just do it. They can drop off, like in 2 seconds, and they can wake up 30, 40 minutes later and be completely refreshed and ready to go. Other people, if they do that long, they're drowsy for the rest of the afternoon and they're shot. So you would sort of say to somebody, look, this is what we're aiming to achieve, which is like a bit of a nap to get some sleep. Start at 20 minutes and maybe add 5 minutes at a time. But if you start to feel you're not bouncing out of that nap quickly, then you probably drifted into your deep sleep cycle, and that's as far as you can go.
Yeah. Thank you.
You're very welcome. Thank you.
All right, I think we might leave it there, Doug. Thanks so much for your time today.
You're very welcome. Thanks for hosting us, Peter. Yeah, thanks very much.
Thanks, everyone. Have a great night. Thank you.